Now, we're going to start this session, please, okay? Now, this session is quite interesting because it's going to be about COVID-19 in pregnancy. In Egypt, our national guidelines do not conform 100% with the international guidelines. So what we need to do is to look at some of our valued speakers and see the data, and we might have a few questions for them. Now, our first speaker is one of the most eminent speakers in obstetric medicine or medical disorders in obstetrics, Catherine Nelson Piercy. She's a consultant obstetrician physician at Imperial College Healthcare NHS Trust and Guy's and St. Thomas Hospital. All right, now this will be recorded, but we hope everybody will be with us. Thank you.
My name is Professor Catherine Nelson Piercy. I'm an obstetric physician from London, the UK, and my talk is entitled COVID-19 in Pregnancy. So my title is COVID-19 in Pregnancy. These are my conflicts of interest. We know that pregnant women are more susceptible to certain infections, particularly viral infections. So they are more prone to get influenza and varicella, particularly varicella pneumonia. But at the beginning of the pandemic, we did not know whether they were more likely to suffer with COVID. They're also more likely to get severe malaria. These are the clinical features of COVID, which are well known to you. The ones marked with the asterisks are the symptoms that I had when I had COVID. So note, I did not have a fever, but fatigue, myalgia, sputum production, impaired taste and smell, and headache. We know that for non-pregnant patients, about 80% have mild disease or no symptoms. 5% require intensive care unit, and the mortality is less than 1% overall. And one of the early studies of pregnancy showed very similar pattern: 86% mild disease, 9% severe disease requiring oxygen, under 5% requiring ITU. And at the beginning, we weren't very sure what the mortality was. But what became very clear with COVID, if you see here, the blue line, is this very clear relationship with increased mortality with increasing age, much more obvious than with influenza, which tends to affect, increases the risk of death in much older patients. And you can see here the 1918 influenza pandemic. But for COVID-19, the risk of death increases very abruptly from about the age of 40 onwards. So this was a study performed in the US of universal screening of pregnant women admitted for delivery. So it took place in March and April in 2 New York hospitals. They screened over 200 pregnant women. 85% of the women were screen negative. 13.5% were positive but asymptomatic, and only under 2% were positive and symptomatic. But this is a very important study because we realized that on every labor ward, there were women who tested positive for COVID who were completely asymptomatic. This is the large UK obstetric surveillance system study. So this collected all cases of COVID in the whole of the UK from the 1st of March to the 14th of April, almost 430 women, and that gave us an admission rate of almost 5 per 1,000 maternities. Most of the women were in their late 2nd or 3rd trimester. 10% required some sort of respiratory support, and we found the same themes as in non-pregnant patients, with an increased proportion of women from Black and minority ethnic groups, older women, so in pregnancy that was defined as over 35, and obese and overweight women, with an increased proportion of women with diabetes, gestational diabetes, and hypertension. But the important finding in the UK was that over 50% were Black and minority ethnic groups compared to 14% of the overall obstetric population. So these are the results of the UCOS study in more detail, and you can see here 69% were overweight or obese, 56% were Black or minority ethnic groups, and most women were in the late 3rd trimester. So 25% were 32 to 36 weeks, and a third were more than 37 weeks presenting at term. This shows you within Black and minority ethnic groups, the majority, 28%, were Black women. And here you can see 10% needed critical care, 74% delivered at term after 37 weeks, and the number of women having caesarean sections for a maternal indication due to COVID was 16%. The overall caesarean section rate was higher than this. But importantly, we saw early on that 95% of the babies were swab negative, and that neonatal transmission was probably the cause of most of the positive babies rather than in utero transmission. These are data from intensive care units in the UK. This column shows patients with COVID, and this shows patients with other viral pneumonias. And you can see, as in other studies, that with COVID, Asian people are more likely to be affected with COVID, as are Black people, compared to other viral pneumonias. And in this study, of over 10,000 cases, 9% were pregnant or postpartum. This is a study that concentrated just on maternal death in COVID at the height of the pandemic between March, April and May. 9 women died during pregnancy or up to 6 weeks after delivery. 1 had a late death after 6 weeks postpartum. And 7 of these women died directly due to COVID. 6 from cardiorespiratory complications, 1 from cerebral venous thrombosis, and 1 where we could not work out why she died peripartum because she didn't undergo a post-mortem. 2 other women died with COVID, but not due to COVID. So from that publication, new recommendations were published, which I think are applicable around the world. You need a team to look after COVID positive pregnant patients who are sick, because if you just leave them under the medical team, they don't understand the need for birth to sometimes help treat the mother. Pregnant women should not be excluded from receiving antiviral and other trial drugs for COVID. And women need to be advised not just to stay at home. If they get sick, there were cases of maternal death where the woman was getting more sick and more breathless, but she didn't present to hospital. Clinicians need to be aware of the risk associated with Black and Asian ethnicity. And all women admitted with confirmed or suspected COVID who were pregnant were given prophylactic low molecular weight heparin because of the increased risk of venous thrombosis associated with this disease. If they got admitted to the intensive care unit, then the dose of heparin was increased. You need senior doctors to make a decision about where to manage these patients, and very importantly, to recognise the signs of decompensation, an increased oxygen requirement, an increased respiratory rate, any drowsiness, and these cases need to be escalated urgently. Lockdown worked. So as soon as we went into lockdown, the number of active cases fell and the number of recovered cases started to increase. So if you go into lockdown, then you reduce the number of active cases of COVID. This is a very important publication. It was published last week in the BMJ, and it's what's called a living systematic review and meta-analysis of all COVID reports of COVID disease in pregnancy. It includes 77 studies where 28 were included, over 11,000 pregnant women with COVID. Most studies were from the US and China, 3 each from the UK and France. If you take universal screening of COVID in pregnancy, then 7% of women were found to be positive, of which 3/4 were asymptomatic. But if you screen just women because they're symptomatic, then 18% are positive. And overall, in this systematic review, there were 13% severe COVID cases, 4% were admitted to intensive care, 3% ventilated, 0.4% required extracorporeal membrane oxygenation, and 0.1% of women died. So 1 in 1,000 women died. What this systematic review also shows is that if you compare pregnant women with non-pregnant women with COVID, then the pregnant women are less likely to have fever and less likely to have myalgia. So they can pass more commonly asymptomatic. If you now compare pregnant COVID patients with non-COVID patients, you can see here that pregnant patients with COVID are 71 more times likely to go to ITU and 3 times more likely to have a preterm birth, and their babies are 3 times more likely to be admitted to the neonatal intensive care unit. The risk factors for severe COVID in this very large study were, as shown in the smaller studies, increased maternal age, increased BMI, chronic hypertension, and pre-existing diabetes. So overall, this large systematic review and meta-analysis shows that pregnant women versus non-pregnant women with COVID manifest fewer symptoms, particularly fever and myalgia. They have an increased rate of admission to the intensive care unit, an increased need for invasive ventilation. And the high-risk conditions are those women with pre-existing comorbidities, obesity, and advanced maternal age. So obstetricians need to balance the need for regular multidisciplinary antenatal care with unnecessary exposure of pregnant women to COVID if you bring them into the hospital. And if you're managing pregnant women with COVID, they need to be in a unit where there are facilities for preterm delivery, bearing in mind that 17% of these women are delivered preterm and 6% of those are due to spontaneous preterm delivery. You will be familiar with this graph, which shows the phases, the stages of COVID. This phase is early infection, which is often asymptomatic. Then you have the pulmonary phase where women become breathless and need oxygen. And then you have the very dangerous hyperinflammation phase. And as people progress through these stages, the mortality increases, the chance of needing oxygen, invasive ventilation, intensive care unit increase. And these are all pictures of pregnant women with COVID. This woman has COVID positive, but is asymptomatic. This woman has a cough and pneumonia, and this woman is developing hyperinflammation and becoming very sick. How do we predict the course of COVID in pregnancy? Well, the important measurement that every woman should have is repeated measurement of oxygen saturation, because hypoxia is the best marker for severity. You also need to look at lymphocyte counts, D-dimer, ferritin, CRP. As you know, chest x-rays are safe in pregnancy, as are CT scans. And this shows a very typical CT scan of COVID pneumonia in pregnancy. This paper was also published very recently. It doesn't relate to pregnancy, but it's interesting. It's trying to work out across the UK how you predict which patients are likely to die with COVID. So it included 35,000 patients with a mortality rate of 30%, and then it validated the score in another data set of 22,000 people where the mortality rate was 30%. And they developed a score, which they called the 4C mortality score. And these are the 8 features which predict mortality: age, gender, number of comorbidities, respiratory rate, peripheral oxygen saturation, any drowsiness, urea, and CRP. Now, obviously in pregnancy, this shows you the ROC curve, and their score performs very well with high sensitivity and specificity compared to other measures of mortality risk. But in pregnancy, we can't use age because most of our patients are below 50, and we can't use gender because all of our patients are female. But probably these other features are predictive of mortality in pregnancy, just like they are outside pregnancy. So as I've said already, women with comorbidities, women who are tachypneic, women who are hypoxic, drowsy, who have impaired renal function and a raised CRP. How do we manage patients with COVID? Well, before any of the trials were published, we used to give them antibiotics. Because azithromycin is one of the antibiotics being tested in the recovery trial, we stopped using clarithromycin, but we still give patients antibiotics. And we give all women admitted to hospital pregnant with COVID thromboprophylaxis with low molecular weight heparin. This is the recovery study, which you will have heard of, and the important result, which came out a couple of months ago now from the recovery study, was that dexamethasone, this is not exclusively in pregnant patients, but it included pregnant patients. Dexamethasone reduced death by a third if patients were ventilated and by a fifth in patients requiring oxygen only. Importantly, it did not benefit patients who did not require respiratory support. So it should only be used if women require oxygen or if they are ventilated. And in pregnancy, we don't use dexamethasone, we use prednisolone, and the dose is 40 milligrams by mouth or intravenous hydrocortisone 80 milligrams twice a day. I hope you know by now that hydroxychloroquine does not work for COVID. This is the report in the New England Journal last week, showing no difference in mortality. In fact, if anything, there's an increased mortality with hydroxychloroquine compared to placebo. So hydroxychloroquine should not be used for COVID. What about remdesivir, the antiviral agent? Well, this is another randomized controlled trial, 1,000 patients, and it found that remdesivir shortened the median time recovery from 15 days with placebo to 10 days if patients were given remdesivir. And if you look at the Kaplan-Meier, so this box here shows the overall proportion of patients who recovered, which you can see is significantly higher with remdesivir compared to placebo. So remdesivir reduced mortality from almost 12% to 6.7% by day 15, and from 15% to 11% by day 29. But that wasn't actually clearly significant. This is a small study looking at maternal mortality. So we're back to pregnancy now, looking at deaths of pregnant women in intensive care units. 10 intensive care units in New York, again at the height of the pandemic. Hospitalized pregnant women, there were 462 of them, of which 19% were admitted to the intensive care unit, and 15% of those women died. 25% of those on mechanical ventilation died, and 85% were discharged from the intensive care unit. And of those women, so these 13 women admitted to intensive care unit, their mean age was 33, their mean gestational age of pregnancy was 33, most were multiparous, most were Hispanic, and 54% had comorbidities, 38% were obese. So as I've said, hypoxia is a good marker of disease severity. So the more oxygen that a woman needs, the more unwell they are. But young women tend to compensate well until they're very sick. So in pregnancy, you need to be aware, because you're dealing mainly with young, fit women, of the risk of sudden deterioration. There's been a lot spoken about the risk of venous thrombosis in COVID, and this is another recent study, a systematic review and meta-analysis of the risk of VTE in COVID. Almost 34,000 patients identified in these studies, of which 28 were included, and the overall prevalence of VTE was 14%. 40% if you screened everyone with ultrasound, but if you just relied on symptoms, then it was 9.5%. And obviously, the prevalence of VTE is much higher once you get to ITU, so 22%, of which 14% were PEs. But in non-ITU patients, it's about 8%. And these women with VTE, or these people with VTE, I should say, had higher baseline D-dimer measurements. But D-dimer is also a measure of inflammation. So what we're seeing in COVID is the more hyperinflamed you are in that third stage of the disease, the higher your D-dimer, the higher the risk of VTE. But remember, in this study, the mean age was 63 years old, and 60% of these patients were male. So the risk of VTE in pregnancy may well be lower than that. However, because it was flagged up early on that VTE was a risk in COVID, the RCOG guideline included a very clear instruction that all women admitted to hospital with COVID, all pregnant women, should receive at least 10 days of prophylactic low molecular weight heparin after discharge and during admission, and also after birth, regardless of mode of delivery. And that was following closely the RCOG VTE guideline. So I'm going to finish by talking about differential diagnosis, because in the height of the pandemic, everybody assumed that every woman with a cough, every woman who was breathless had COVID. But there are other causes of breathlessness and fever in pregnancy, particularly other causes of sepsis, chorioamnitis, asthma, and pulmonary edema. And I saw all of these three situations in pregnancy where the woman was wrongly assumed to have COVID. So you need to avoid COVID centricity. And I would commend to you this guideline called the Acute Care Toolkit about managing acute medical problems in pregnancy, published by the Royal College of Physicians. And it goes through the differential diagnosis of breathlessness, chest pain, as well as abdominal pain, fever, and sepsis in pregnancy. Moving now to practical considerations on the labour ward. All women should be managed as having COVID with regard to PPE until you get a negative swab, and try and corral the COVID positive and suspected COVID positive patients at one end of your labour ward. Try and have midwives and doctors looking after either COVID positive patients or COVID negative, but not both. And at the height of the pandemic in the UK, we had a whole COVID team with a second consultant obstetrician, obstetric anaesthetist, and physician teams. And you need very clear guidelines for escalation and when to refer to critical care outreach. At the same time, you have to think about how to shield the highest risk women, for example, your pregnant renal transplant patients. So this is the escalation policy that we had. It went from green to purple for peri-arrest, and it was entirely dependent on the level of oxygenation. So here is where you start to worry, is that women, they maintain their saturations, but they need 4 litres of oxygen. And these women, because they need oxygen, they are at risk of deterioration. So you need to think about delivery, think about giving them steroids for fetal lung maturation if they're less than 35 weeks. These women, by the time they are increasingly hypoxic, despite oxygen, then you need very careful consideration about urgent delivery. So just to give you an idea, this was in the first wave of the pandemic in my hospital. We had 27 positive patients. And 3 went to the intensive care unit. They all survived and were stepped down. Nearly all of them were in the 3rd trimester. Many were Black, Asian, diabetic, hypertensive, or obese, or a combination of all those. And both women who required oxygen required delivery, and both were over 40. So although people under 50 are less at risk than people over 80, there's already a gradient once you get to women above 40 years old. So my key messages are that you need a lot of reassurance and education of midwives, and everyone needs to work as a team. Hypoxia is the most important marker of severity, and therefore pregnant women with COVID need to have their oxygen saturations monitored. Don't forget other obstetric and medical diagnoses. Don't forget thromboprophylaxis. You need to escalate if there's worsening hypoxia, and you need a multidisciplinary senior individualized decision about whether you should deliver women but you should consider that in all women over 26 to 28 weeks who are requiring oxygen. Therefore, you need to consider giving steroids and magnesium sulfate, and share the lessons. Those units having more cases need to share the lessons with those units having less cases. Thank you very much for your attention.